$6.5 billion in fraudulent Medicare claims, more than the entire annual operating budget of the city of Miami. And every dollar of it was billed by someone with a medical license. If you pay Medicare premiums, if your parents carry that red, white, and blue card, if your retirement math assumes Medicare will function the way it was promised, this already hit your household. Not theoretically, actuarially. The premium increase you absorbed last year was calculated against a fraud loss that was already in the system before anyone was charged. There is a billing code at the center of this story. One code. Submitted at a 2,000% markup, processed automatically, paid without a human being ever looking at it. The auditors had the data. They reviewed less than 4%. Processed, approved, dispersed. On June 23, 2026, the Department of Justice charged 455 defendants across 45 states in the largest healthcare fraud takedown in American history. What this story is really about is not the arrests. It is the 6 years the payment system kept writing checks while the evidence accumulated in plain sight. I had this story half-written under a different angle. The international fugitives, the Philippines arrest, the FBI extraction from Turkey. Then I found the 2019 CMS proposal that changed the entire shape of it. A specific, budgeted plan to monitor the exact billing category that would go on to produce $2 billion in fraudulent payments. It was reviewed. It was deferred. What followed is the reason this episode exists. If you had a family member on Medicare in the early 2000s, you watched them carry that card to every appointment, the one with the flag on it, the one that felt like a covenant after a lifetime of payroll deductions. That card and what it was supposed to guarantee is exactly what was being billed against. Not by strangers working outside the system, by licensed physicians working inside it. How much of your premium increase over the last 3 years was subsidizing fraud you had no way of detecting on your statement? And why is Congress still running the same payment architecture that made $6.5 billion in false claims not just possible, but automatic? If the program underwriting your retirement healthcare makes billing decisions like this one, and you would have had no way of knowing until 455 people were arrested, subscribe. One documented story every week covering the decisions behind the money and the people who made them. The $1,400 square centimeter. By 5 a.m. on June 23, 2026, federal agents were already positioned at doors in 45 states. 200 Department of Justice attorneys, 50 state Medicaid fraud control units, 56 federal judicial districts coordinated simultaneously, the largest law enforcement mobilization in the history of American healthcare. But you don't know this yet. There is a single line in the 2019 CMS budget review that the people who look like the heroes of this takedown saw, noted, and chose not to fund. That decision will take about 12 minutes of this story to reach. It is the reason the number was $6.5 billion instead of something much smaller. The largest individual scheme in the takedown was built in Arizona, and its elegance is the kind that should unsettle you, because it was invisible inside a system that was never designed to look. Tissue banks harvest human tissue, skin grafts, allografts, and sell processed grafts to distributors and medical providers. Medicare reimburses providers for applying those grafts to patients. The reimbursement rates are high because the underlying tissue is legitimately expensive to process, store, and transport. That pricing structure created a gap between what a graft costs and what Medicare will pay for it. Someone in Arizona found that gap and drove a truck through it. A network of companies began purchasing allografts from tissue banks, relabeling them and reselling them to providers at a markup of 2,000%. The price billed to Medicare per application? $1,450 per square centimeter. To make that number physical, a standard sheet of printer paper is roughly 600 square centimeters. At that billing rate, one sheet of paper-sized graft material would cost Medicare $870,000. total billing submitted to Medicare from this single scheme? Over $4 billion. Total amount Medicare actually paid? Over $2 billion. More than NASA's entire annual budget for the Artemis Moon program, dispersed through the same automatic processing pipeline that handles your doctor's routine office visit. The mechanism that kept the Arizona operation expanding was a kickback structure, paying referring parties 40% of every sale. Physicians received payments, distributors received payments. The network grew because the math was simple for everyone inside it. Refer patients, bill Medicare, collect 40 cents on every dollar. One defendant in this case spent more than $24 million of fraud proceeds on luxury real estate, automobiles, and watches. The itemized receipts are in the federal indictment. And somewhere in Florida, far from the Arizona tissue labs, a different kind of scheme was running on a different kind of currency. Not tissue markups, but parental fear. A medical director of a cardiology practice was deploying mobile cardiac testing units directly onto school campuses, screening student athletes for sudden cardiac death risk. The marketing pitch to parents was a fear that is entirely real. The tests, in hundreds of cases, were not. The medical director signed results he had not reviewed. Parents brought their children home believing a physician had cleared their hearts. Total billing from that operation? $89 million. The signal was there. It had been there for some time. Medicare's own data systems flagged anomalous billing volumes from certain provider networks beginning in 2021. The automatic payment processing continued without interruption. The $2 billion paid out in the Arizona scheme did not move through a hidden channel or a hacked database. It moved through the standard Medicare claims pipeline, submitted, processed, approved, dispersed. The same way every legitimate claim from your family doctor travels through the system today. Rubber stamps and school gymnasiums. The Florida cardiac scheme deserves its own weight in this story because its cruelty is more precise than the Arizona operation and more personal. Short sentences first. A school gymnasium, a table with EKG equipment, a line of teenagers in athletic shorts. The mobile units appeared on Florida school campuses with the institutional look of a public health initiative. Parents signed consent forms. Students received electrocardiogram screenings. Results were returned with a physician's name and signature. $89 million was billed to Medicaid and private insurers over the life of the operation. The physician whose signature appeared on those results now faces federal charges for signing off on tests he did not review. Set the numbers aside for a moment. I'll be honest, I didn't expect the detail to be this specific. One parent in Florida brought a 15-year-old to what looked like a legitimate cardiac screening at their child's school. A doctor's name was on the paperwork. The results came back with a clearance. That parent drove home in a used Camry believing a cardiologist had reviewed their child's heart rhythm data. The cardiologist had not opened the file. The signature was already on the form before the test was administered. The paperwork looked like medicine. The liability it created was real. The review never happened. Now here is where the official version breaks apart. CMS officials and Medicare administrators have repeatedly maintained that prepayment review systems protect the program from large-scale fraud. The record shows something different.
In 2022, CMS processed over $1 trillion in claims. The prepayment review rate, the share of claims subjected to any form of manual or algorithmic scrutiny before payment was authorized, was under 4%. Over 96% of all Medicare claims were paid first and reviewed, if at all, afterward. $2 billion in fraudulent tissue graft payments moved through that pipeline, submitted, approved, dispersed, without triggering a prepayment stop from 2020 through at least 2026. Both the Arizona Tissue Scheme and the Florida Cardiac Scheme required a licensed medical professional to function. In Arizona, physicians were needed to receive kickbacks and submit the billing codes. In Florida, a physician's signature was needed to authenticate results and authorize claims. The license was not a guardrail. It was the key that opened the door. If the system meant to protect 67 million Medicare beneficiaries reviews fewer than 4 out of every 100 claims before paying them, and you are one of those 67 million, subscribe. That is the kind of structural fact this channel exists to document. CMS has calculated that the Arizona Tissue-Graft scheme alone, if it had continued undetected at the same volume, would have added $11 per month to every Medicare beneficiary's Part B premium. 67 million enrollees. Multiply that. That is not a policy abstraction. That is $340 a year per person absorbed into the premium structure to cover losses from a billing code that no one stopped for 4 years. The international arrest records from the June 2026 operation confirm something else. The infrastructure behind these schemes was not improvised, and it was not domestic. The architecture of distance. Ibrahim Hilmi is accused of orchestrating a $3.7 billion Medicare fraud scheme, described by FBI Director Kash Patel as one of the biggest healthcare fraud investigations in Bureau history. In May 2025, Hilmi left the United States before authorities could arrest him. Turkish authorities tracked and arrested Hilmi in Turkey. On June 19, 2026, he arrived back on American soil on a private plane, photographed in light blue detention clothing, hands shackled, flanked by FBI agents. Among the businesses named by prosecutors, Sunshine Senior Solutions. This is not a new story. The pattern of licensing a medical professional, building a billing entity around their credentials, and submitting automated claims at volume has appeared in federal healthcare fraud cases going back to the mid-1990s. The technology changes. The bandwidth of the fraud scales with the processing speed of the payment system. The fundamental mechanism has not changed in 30 years. Herb Kimble, fugitive in a separate $1.2 billion telemedicine and durable medical equipment scheme, was apprehended in the Philippines on June 8th. Indicted June 16th in South Carolina on 3 counts of failure to appear. Khalid Satary, wanted in a $547 million genetic testing fraud, is believed to be in the United Arab Emirates. Emylee, wanted in a $90 million genetic testing scheme, fled to Vietnam via private charter using a fake passport. When fraud operators reach the scale of multiple billions in claims, they build operational redundancy that only functions if some of the key personnel and some of the money are outside U.S. jurisdiction. Extradition takes years. Asset recovery from foreign accounts takes longer. Several individuals arrested abroad had been on federal watch lists for 18 months or more before the June 2026 operation. The deferred 2019 CMS proposal is closer now. 6 days before the Arizona Tissue Network began scaling its billing in early 2020, the budget authorization window for that real-time anomaly detection expansion closed without action.
A single licensed nurse in Nevada is charged with billing Medicaid for nearly $1 billion in skincare services. One individual, one billing category, one state. Just under $1 billion. That number requires sustained, systematic filing over an extended period. Not a one-time exploit, but a running operation that the payment system processed without interruption long enough to accumulate a 10-figure total. The executives and regulators who designed the claims processing architecture that allowed prepayment review on under 4% of submissions made a specific choice about speed versus scrutiny. The 67 million beneficiaries whose premiums absorbed the actuarial cost of that choice were not consulted. The penalty for the design decision falls on a different population than the one that made it. And while the Department of Justice was coordinating the largest fraud takedown in Medicare history, the companies managing Medicare Advantage plans, the private insurers that administer Medicare for tens of millions of Americans, were settling their own fraud cases. Kaiser Permanente agreed to pay $556 million in January 2026 for submitting roughly 500,000 invalid diagnosis codes between 2009 and 2018. Aetna, a CVS subsidiary, settled for $117.7 million in March 2026. UnitedHealth Group faces ongoing DOJ litigation over alleged upcoding. The same billing infrastructure, the same vulnerability, different defendants. The board reviewed the auditor's data on the Arizona Tissue-Graft anomalies. The memo documenting the anomaly was circulated 6 weeks before the final budget vote on expanded monitoring. No one on the call asked to revisit it. Verdict. On the morning of June 23, 2026, the deferred 2019 proposal reached its consequence. Not because the billing system self-corrected, because a multi-year joint investigation coordinated across 56 federal districts accumulated enough evidence by human effort to support 455 simultaneous criminal charges. The automated payment pipeline that had processed the fraudulent claims for 6 years is still running the same architecture today. I've stopped assuming that a regulatory body funded what it reviewed. This case is why. Here is what this story documents, reduced to its structure. 1. Medicare's payment speed is the vulnerability, and it is a vulnerability by design. The system was built to pay claims fast because denying or delaying legitimate claims for 67 million beneficiaries is politically impossible and medically dangerous. Every structural decision that increased processing velocity also widened the window for fraudulent claims to clear before review. The fraud scaled in direct proportion to the payment speed. The Arizona Tissue Scheme submitted claims that were paid in the same cycle time as a legitimate office visit, because the system does not distinguish between the two until after the money has moved. 2. A medical license is not a safeguard. It is an access credential. 90 of the 455 defendants in this takedown held active medical licenses at the time of their arrests. The Arizona scheme required licensed providers to receive kickbacks and submit billing codes. The Florida scheme required a licensed physician's signature to authenticate cardiac test results. In both cases, the license was not the barrier that failed. It was the tool that made the fraud functional. 3. The gap between who chose the payment architecture and who absorbs the cost when it fails is not an oversight. It is a structural feature. The regulators who maintained the under 4% prepayment review rate through the period when the Arizona scheme was scaling had access to the 2019 proposal that would have flagged the specific billing codes involved. The 67 million enrollees whose premiums rose to absorb the actuarial loss did not know the proposal existed. The people who deferred the funding moved on. The people who paid the premium increase are still enrolled. The agents who executed the June 23rd arrests recovered $182 million in cash, vehicles, real estate, and jewelry. Against $6.5 billion in fraudulent billings, that is a recovery rate of under 3%. For every dollar recovered, more than $33 remain unaccounted for. And the same architecture is not theoretical, it is current. Kaiser Permanente's $556 million settlements in January 2026, Aetna's $117 million settlements in March 2026, UnitedHealth Group's ongoing litigation. The DOJ recorded over $2.9 billion in False Claims Act settlements in 2024 alone. If you hold shares in a healthcare fund, a Medicare Advantage insurer, or a broad index that includes CVS, UnitedHealth, or Elevance, the legal exposure from these billing structures is already in your portfolio. The question is whether the people managing those positions have read the same case files you just heard. The documents are public. Draw your own conclusions.